Hello everyone, today we're going to discuss the anion gap and how it relates to metabolic acidosis. The anion gap will look at cations and anions within the blood. So normally it's sodium plus your potassium minus your chloride plus your bicarb. There is some debate of using albumin, make sure you correct for albumin as it relates to the pH. However, let's make this simple. There's not much potassium in the blood, so that number doesn't help us out too much, so that can go away. And I don't like to correct for albumin because it takes more work, so let's keep this simple. Simply put, sodium minus chloride plus bicarb is our anion gap. When we look at a normal anion gap, which is any number from 4 to 12, everyone will tell you different numbers, but we're going to go with 4 to 12 today. Simply put, it's either too much chloride or not enough bicarb. Too much chloride can be seen with IV, such as sodium chloride infusions, and bicarb loss can be seen with diarrhea. But it's that simple. Too much chlorine or loss of bicarb. In addition to this, we can see a normal anion gap metabolic acidosis with renal failure and exogenous meds like TPN. The relationship between chloride and bicarb is because both of these ions are anions, meaning they're both negatively charged. So if our bicarb is lost, as we can see with renal failure or just GI losses, the chloride will naturally increase because it wants to keep the ion concentration within range. Therefore, high chloride, low bicarb is something we can normally see. Increased anion gap, or a number greater than 12, or whatever number you want to use, has a much more broad spectrum of causes. For that reason, a lot of people like to use acronyms when looking at this, such as mud piles, where M is going to be our methanol, U is going to be uremia, D for DKA, P for paraldehyde, I for iron, L for lactic acidosis, E for ethanol, and S for salicylates. Now, I like to use COLT, where K is going to be our ketones, U for uremia, L for lactic acidosis, and T for toxins. I like it because it's more general. The ketones are not just from DKA. We can also have ketonuria from alcoholics or people in starvation. Their uremia is usually patients that have end-stage renal failure, and I mean GFRs less than 20. When we look at lactic acidosis, we have to remember that there is a type A, type B. Majority of people that use lactic acidosis are looking for profound hypotensive shock, where the oxygen is not getting to the tissue. But there's also type B lactic acidosis, where some drugs that we use, such as epinephrine or albuterol that are working on those beta-2 agonists, can cause this lactic acidosis. Other things like propofol infusion syndrome, which we usually see with pediatrics, can also cause this. Toxins are then salicylates, one of the more common ones such as aspirin, cyanide, carbon monoxide, and some NSAIDs. Thank you so much for listening. If you enjoyed it, go ahead and give us a like. Take care.